Hello and welcome to our webinar on screening mammography. My name is Jennifer Boniface and I am one of the nurse analysts with the Provider Outreach and Education team. Today's webinar will focus on the clinical aspects for the Medicare preventive service of screening mammography for detecting breast cancer. I have a few housekeeping items to go over with you before we start the webinar. You can find the link for the encore presentation of this webinar on our website's Training Center page at www.wpsgha.com, and it will be accessible for the next 60 to 90 days. Additionally, the recording will be uploaded to our YouTube channel under the Encore Presentations playlist, and both should be available within the next 15 business days. If you have any questions, please put those questions into the chat. We will answer questions as time permits. Should we be unable to answer a question during the webinar, we will create a follow-up document and send it to all attendees afterward. We really want your feedback. It helps us develop the education on topics that may be of interest to you. Consider taking our survey to let CMS know what you did like and what topics you'd like to learn more about. And Mary Sue placed a link to the survey into the chat. There will also be an opportunity at the end to take the survey. Additionally, if you're listening on this recording, you can provide feedback by completing the survey while viewing the encore presentation. To access that survey, click the circle with the eye in the upper right corner of the video, and a link to the survey can also be found in the description of the video. On this next slide, we have our disclaimer. Medicare rules change often, so please make sure you're looking at official CMS communications for the most up-to-date rules and regulations. These do take precedence over anything presented today. And as a reminder, CMS prohibits recording of this presentation for profit-making purposes. This presentation is being recorded by us and will be posted on the Training Center page on our website under Encore Presentations, as well as on our YouTube channel under the playlist Encore Presentations. On the next slide, you'll see several acronyms used during this presentation. Many of them you already know, but if you do find an acronym that we discussed today that you're not familiar with, please refer to this slide for guidance or type in the chat. Mary Sue can help you out with that. So let's get started. Each October, we observe National Breast Cancer Awareness Month to highlight the importance of early detection and support. According to the National Breast Cancer Foundation, a woman is diagnosed with breast cancer every 2 minutes in the United States. Approximately 30%, or 1 in 3 of all newly diagnosed cancers in women each year are breast cancer. However, women who undergo regular breast cancer screening have a 26% lower mortality rate from the disease compared to those who are not screened. Annual screening can help detect cancer early, allowing for timely diagnosis and treatment. Medicare Part B covers screening mammography as part of its preventive services benefits for eligible beneficiaries. This is the perfect time to remind your patients of the importance of scheduling yearly breast cancer screenings as a vital part of their preventive healthcare plan. Our objective for today is to provide an overview of the clinical aspects for the Medicare preventive service of mammography screening. We will cover background information about breast cancer, screening and tests used to detecting breast cancer, treatment options, strategies for prevention, and Medicare Part B coverage criteria for screening mammography. We'll begin by discussing some important facts and statistics about breast cancer. The American Cancer Society reports that, excluding skin cancers, breast cancer is the most frequently diagnosed cancer among women in the United States. Breast cancer ranks as the second leading cause of cancer-related deaths among American women. About 1 in 8, or approximately 13% of the U.S. female population, will be diagnosed with breast cancer at some point in their lives. Additionally, an estimated 1 in 43 women, or 2.3%, will lose their lives to the disease. In 2025, the American Cancer Society estimates approximately 316,950 new cases of invasive breast cancer and around 59,080 new cases of ductal carcinoma in situ. It is also projected that an estimated 42,170 women in the U.S. are expected to die from breast cancer. Although breast cancer can affect both men and women, Less than 1% of all breast cancer cases in the United States are diagnosed in men. Today's webinar will focus on the Medicare breast cancer screening guidelines as they apply specifically to women. There are two types of breast conditions, benign and malignant. To understand the difference between the two, it's important to first explain the types of tumors that can develop in the breast. A tumor is an abnormal mass of tissue that forms when cells divide and grow uncontrollably. Benign breast tumors are non-cancerous and do not metastasize to other areas of the body. While benign tumors are typically not life-threatening, the presence of some benign conditions, such as atypical hyperplasia, can increase a person's chance of developing breast cancer later on. In contrast, malignant breast tumors are cancerous. These tumors develop due to the proliferation of cancerous cells in the breast tissue. These malignant cells begin to multiply and may metastasize to lymph nodes or other parts of the body. Different types of breast cancer originate in different parts of the breast. The types of breast cancer diagnosed is determined by the specific breast tissue cells involved, as well as whether the cancer has metastasized. In situ cancer remains confined to its original location and has not spread into surrounding breast tissue. In contrast, invasive cancer has spread beyond its point of origin into nearby tissue. The majority of breast cancers are carcinomas, a type of cancer that begins in epithelial cells. The most common type of breast cancer is adenocarcinomas, which originate from the glandular cells in the milk ducts or lobules. Examples of adenocarcinomas include ductal carcinoma in situ, invasive ductal carcinoma, and invasive lobular carcinoma. Ductal carcinoma in situ, or DCIS, is a non-invasive form of breast cancer. It begins in the cells lining the milk ducts, but remains confined and does not spread to the surrounding tissue. Although DCIS is not non-invasive, it is considered a precursor to invasive adenocarcinoma. Invasive ductal carcinoma, or IDC, starts in the milk ducts but spreads into nearby breast tissue. It can potentially spread to other parts of the body through the lymphatic system or bloodstream. Invasive lobular carcinoma, or ILC, originates in the lobules, the glands responsible for producing breast milk. It can invade nearby breast tissue and may spread to other parts of the body. Two examples of breast cancer subtypes are HER2-positive breast cancer and triple-negative breast cancer. HER2-positive breast cancer is a type of cancer where the HER2 protein causes cancer cells to grow quickly. It most often appears as invasive ductal carcinoma, but can also occur in invasive lobular carcinoma and other less common forms. This cancer usually begins in the milk ducts, but in some cases it can develop in the lobules, as seen in HER2-positive invasive lobular carcinoma. Rarely, it can affect the nipple area as part of Paget's disease or involve the skin or lymph vessels, as seen in inflammatory breast cancer. While HER2-positive breast cancer is considered aggressive, it often responds well to targeted therapies. Triple-negative breast cancer, or TNBC, is another aggressive subtype that lacks estrogen, progesterone, and HER2 receptors. It's most commonly presents as invasive ductal carcinoma. In rare cases, it can present as invasive lobular carcinoma. Because it lacks hormone and HER2 targets, triple-negative breast cancer is more difficult to treat and tends to have a higher risk of recurrence compared to other subtypes. Other less common subtypes of invasive breast cancer include adenoid cystic carcinoma, low-grade adenosquamous carcinoma, medullary carcinoma, metaplastic carcinoma, micropapillary carcinoma, mixed carcinoma, mucinous or colloid carcinoma, papillary carcinoma, and tubular carcinoma. Certain types of invasive breast cancer, such as inflammatory breast cancer and metaplastic breast cancer, have distinct characteristics and patterns of development. Inflammatory breast cancer is a rare and aggressive form that causes redness, swelling, and warmth in the breast, often without a noticeable lump. Metaplastic breast cancer is also rare and aggressive, marked by a presence of different cell types. Both subtypes are typically more aggressive and more common forms of breast cancer. Finally, breast cancer can also develop in other types of cells within the breast. These cancers are rare. Paget's disease of the breast is a cancer that typically develops in the nipple and the areola. Angiosarcoma is a malignant tumor that forms in the inner linings of blood vessels or lymphatic vessels within the breast. Fluid tumors form in the connective tissue of the breast. They can be benign or malignant. Although the exact cause of most breast cancers remain unknown, certain risk factors can increase a woman's likelihood of developing it. The risk factors can be classified into two categories: non-modifiable, or those we cannot control, and modifiable, or those we can change. And we'll start with the non-modifiable risk factors. The first non-modifiable risk factor is being female. While anyone can get breast cancer, women are significantly more likely to be diagnosed with the disease. The next non-modifiable risk factor is age. As a person grows older, the risk of breast cancer increases. According to the American Cancer Society, the average age of diagnosis for breast cancer is 62 years old. Race and ethnicity are the third non-modifiable risk factors. White women have a higher incidence of breast cancer compared to Black, Hispanic, and Asian women. However, Black women experience the highest mortality rate due to breast cancer. Per the American Cancer Society's Breast Cancer Facts and Figures 2024-2025, Black women have a 5% lower incidence of breast cancer, but a 38% higher mortality rate compared to white women, due in part to later diagnoses and reduced access to high-quality care. Additionally, 1 in 5 Black women diagnosed with breast cancer have triple-negative breast cancer, a more aggressive and harder to treat form of the disease. This is twice as common compared to the 1 in 10 cases among women of other racial and ethnic groups. The fourth non-modifiable risk factor for breast cancer is family history of breast or ovarian cancer. According to the National Breast Cancer Foundation, approximately 15% of women diagnosed with breast cancer have a family history of the disease. Having a first-degree relative, such as a mother, sister, or daughter, diagnosed with breast cancer nearly doubles a woman's risk for developing the disease. The likelihood of developing breast cancer increases if the woman has multiple affected relatives on either side of her family who have been diagnosed with breast or ovarian cancer, or her family has a history of being diagnosed with breast cancer at an early age, such as before the age of 50. A personal history of breast conditions is the next non-modifiable risk factor. Women who have had a previous diagnosis of breast cancer are more at risk for cancer recurrence. Women with a personal history of benign breast disease are also more at risk for developing breast cancer. The sixth non-modifiable risk factor is having dense breasts. Women with increased breast density have a higher likelihood to develop breast cancer. The breast consists of two types of tissue, fatty tissue and dense tissue. Women who have dense breasts have more dense tissue as compared to fatty tissue within their breasts. This can make it more difficult to detect breast cancer during a screening mammography. The age in which a woman begins and ends her menstrual cycle is another non-modifiable risk factor. Women who start menstruating before the age of 12, as well as those who entered menopause after the age of 55, are at an increased risk for breast cancer due to longer lifetime exposure to estrogen. The eighth non-modifiable risk factor is inherited genetic mutations. Women who carry inherited genetic mutations such as BRCA1, also known as BRCA1, and BRCA2 or BRCA2, have an elevated risk of developing breast cancer compared to those without these mutations. Next is exposure to DES. Both women who took DES during their pregnancies, as well as women exposed to DES while their mothers were pregnant, have a slightly elevated breast cancer risk. The 10th non-modifiable risk factor is previous radiation therapy to the chest. Women who have received radiation therapy to the chest before age 30 to treat previous cancers are at an increased risk for breast cancer later in life. The risk is even more elevated if the woman received radiation therapy during her adolescence or young adulthood, when the breasts were still developing. The last non-modifiable risk factor is having a taller stature. While researchers do not fully understand the underlying cause, studies have shown that taller women have a greater risk for breast cancer compared to shorter women. It is thought that it might be associated with factors such as childhood nutrition, hormonal influences, or genetic predisposition. The next type of risk factors that may increase a woman's chance of developing breast cancer is modifiable. The first modifiable risk factor is being overweight or obese. Following menopause, some women experience an increase in body fat. This surplus fat can raise estrogen levels, thereby elevating the risk of breast cancer. However, it's important to note that excess body fat can occur at any age and can therefore increase the breast cancer risk for women who have not yet entered menopause. Not being physically active is the second modifiable risk factor. Women who are physically inactive may have a higher risk of developing breast cancer. A sedentary lifestyle can lead to weight gain and obesity, both of which are associated with higher levels of estrogen and insulin, hormones that may encourage the growth of certain types of breast cancer. Additionally, not getting enough physical activity can weaken the immune system, making it harder for the body to identify and eliminate abnormal cells. Next is taking menopausal hormone replacement therapy. Long-term use of combination menopausal hormone replacement therapy containing estrogen or progesterone may increase a woman's likelihood for developing breast cancer. The risk decreases once the woman discontinues taking these medications. Additionally, oral contraceptives and hormone intrauterine devices may slightly raise the risk of breast cancer. However, the overall risk remains low. This risk tends to decrease over time once the woman stops using these methods of contraception. The risk increase is often more significant in younger women who've been using these methods for many years, particularly if they've started using hormonal contraception at a young age. Birth control shots, implants, patches, and rings also involve the use of hormones. However, researchers have not conducted enough conclusive studies to definitively determine whether these methods increase the risk of breast cancer. The fourth modifiable risk factor is pregnancy and childbirth. Women who have their first child after age 30 have an elevated risk for developing breast cancer. Women who have never been pregnant are also at an increased risk for the disease. Not breastfeeding is the fifth modifiable risk factor. Breastfeeding, particularly if it's done for a year or longer, may lower a woman's risk for developing breast cancer by helping regulate hormones and eliminating potentially abnormal cells. The sixth modifiable risk factor is smoking. Smoking is linked to a higher risk of breast cancer, especially in premenopausal women. Tobacco contains carcinogens that can damage breast cells. The last modifiable risk factor we will discuss is alcohol consumption. Women who consume alcohol are at an elevated risk for developing breast cancer as compared to women who do not drink. Alcohol increases estrogen levels and may damage DNA in breast cells. The more a woman drinks, the greater her risk for developing breast cancer. So what are some of the signs and symptoms of breast cancer? In some cases, breast cancer may not present with any noticeable symptoms. For some women, they are unaware they even have breast cancer until an abnormality is detected during a routine mammogram. However, many women display some signs and symptoms indicative of possible breast cancer that warrant further examination by a healthcare provider. Signs and symptoms of breast cancer may include a new lump or a noticeable lump in the breast or axilla, also known as the underarm, thickening of tissue of the breast or the axilla, swelling of all or part of the breast, and this may involve the entire breast or just a portion of it, change in the appearance of the breast, including changes in the size or shape of the breast or changes in the color of the breast tissue, and this may include redness or darkening of the skin, skin irritation or dimpling of the skin of the breast, and the skin may appear puckered or have an orange peel-like texture, dryness, flaking, crusting, scaling, or peeling of the skin of the breast or the nipple, changes in the appearance of the nipple, including nipple retraction, nipple discharge other than breast milk, pain in the breast or the nipple, or swollen lymph nodes in the axilla or near the collarbone. It's important to note that these symptoms do not always mean breast cancer is present. Many benign conditions can cause similar changes. However, any new or unusual symptoms should be brought to the attention of the healthcare provider for proper evaluation and follow-up. Breast cancer screening typically begins with a clinical breast exam. This involves a visual inspection and manual palpation of both breasts to identify any lumps, tenderness, asymmetry, changes in texture of the skin or color of the skin, or nipple discharge. The healthcare provider will also examine the lymph nodes in the underarm area, along the collarbone, and near the breastbone for any lumps or abnormalities. The clinical breast exam is included as part of the Medicare Preventive Services benefit under the screening pelvic exam, and the link to MLN 006559 Medicare Preventive Services Screening Pelvic Exam has been added to the slide for your reference. Next, the healthcare provider may also ask about any current symptoms the patient is experiencing, including when they first appeared. A screening mammogram is then performed either on the same day as the clinical breast exam or scheduled for a later day. Screening mammograms are typically performed on women who do not display any signs or symptoms of breast cancer to help identify early signs of breast cancer that the healthcare provider or patient may not detect through routine examination. They can also be used to further investigate any abnormalities discovered during the clinical breast exam, enabling prompt diagnosis and treatment. Screening mammograms use low-dose X-rays to produce detailed images of the breast, typically capturing two standard views, craniocaudal and mediolateral oblique, of each breast. Any changes or irregularities in the breast will appear within these images. According to the American Cancer Society, mammograms can detect several types of breast changes. The first is calcifications, including macrocalcifications and microcalcifications. Calcifications appear as little white dots on the mammogram. Macrocalcifications are usually associated with non-cancerous conditions and generally do not require additional testing. Most microcalcifications do not require biopsy. However, if they exhibit suspicious characteristics and patterns, a biopsy will be recommended to further investigate for cancer. Next are masses, include cysts and solid tumors, followed by asymmetry and distortion of one or both breasts. Finally, there are changes in breast density. For women at high risk of developing breast cancer, a healthcare provider may recommend screening with a breast MRI. However, breast MRI is generally not advised for women at average risk, as it is more likely to produce false positives compared to mammography. While screening mammograms can detect abnormalities within the breast, they cannot determine whether these abnormalities are cancerous. If the screening mammogram shows any abnormal findings, additional testing may be performed to confirm a diagnosis of breast cancer. This process typically begins with performing a diagnostic mammogram. A diagnostic mammogram takes a closer look at the entire breast to assess any abnormalities found on the screening mammogram. It may also be used to evaluate the breast in cases where a woman exhibits signs or symptoms that suggest possible breast cancer. The diagnostic mammogram provides additional images of the breast that are not typically included in routine screening mammograms. Per NCD 220.4 mammograms, Medicare covers the mammogram as a diagnostic test if the patient meets one of the following criteria: has distinct signs and symptoms for which a mammogram is indicated, has a history of breast cancer, or is asymptomatic but based on the patient's history and other factors the physician considers significant, the physician's judgment is that a diagnostic mammogram is appropriate. Following the completion of the diagnostic mammogram, if any suspicious areas are identified, further diagnostic tests may be conducted to investigate the possibility of breast cancer. Additional diagnostic tests may include ultrasound to further assess any lumps that were found or to visualize areas of the breast that may be difficult to see on mammogram, breast MRI, used to examine the breast for symptoms suggesting potential cancer, assess the size and location of any cancerous growths, and identify any tumors that may be present. And breast biopsy, where a sample of the breast tissue is taken to check for cancerous cells and to test specific proteins such as estrogen receptors, progesterone receptors, and the HER2 gene or protein. The results, including the proteins found and the tumor grade, can help determine the cancer stage and guide treatment options. Once breast cancer is diagnosed, staging is performed to determine whether the cancer has spread, and if so, to what extent the metastasis has occurred. Staging plays a critical role in guiding treatment decisions and evaluating the patient's prognosis. Breast cancer stages begin at stage 0, which is carcinoma in situ, that range from stage 1 to stage 4. Stage 0 breast cancer refers to cancer that remains confined within the duct of the breast and has not spread. Stage 4 cancer refers to cancer that has metastasized to distant parts of the body. In terms of staging, the higher the number, the more the cancer has progressed. The TNM system, developed by the American Joint Commission on Cancer, is the most commonly used staging system for breast cancer. This system can be divided into two types of stages, pathological and clinical. The pathological stage, also known as the surgical stage, is determined by examining tissue samples removed during surgery to assess the extent of the cancer. If the surgery is not performed, the clinical stage is used to guide treatment. The clinical stage is determined by analyzing data obtained from the physical exam, as well as results from any biopsy or imaging tests performed. It's important to note that the clinical stage is less precise compared to the pathological stage. Several key terms are used to describe the stage and characteristics of breast cancer. T stands for the extent or size of the tumor. It describes how far the cancer has grown into nearby structures or organs. N refers to the spread to nearby lymph nodes. It describes whether the cancer has metastasized to these nodes or not. M stands for the spread or metastasis of the cancer to distant sites. It describes the extent in which the cancer has spread to distant organs, including the liver or lung. ER represents whether the cancer contains an estrogen receptor. PR indicates whether the cancer contains a progesterone receptor. HER2 represents whether the cancer is producing too much HER2 or human epidermal growth factor receptor 2. This protein stimulates the cancer cell growth. And G denotes how closely cancer cells resemble normal cells, helping to predict how quickly the cancer might grow and spread. We will not be discussing in detail what each stage describes during this webinar. For more in-depth explanation about breast cancer staging, please refer to the American Cancer Society's breast cancer stages. Breast cancer treatment is determined by the type and stage of the cancer. Available treatment options may include surgery, radiation therapy, chemotherapy, hormone therapy, targeted drug therapy, and immunotherapy. The first treatment option is surgery. There are two main types of surgery performed, breast-conserving surgery and mastectomy. Breast-conserving surgery involves removing the tumor along with a margin of the surrounding healthy tissue. Examples of breast-conserving surgery include lumpectomy, partial mastectomy, segmental mastectomy, and quadrantectomy. Mastectomy involves the removal of the entire breast as well as any surrounding tissue if necessary. A single or unilateral mastectomy involves removal of one breast, whereas a double or bilateral mastectomy involves removal of both breasts. Lymph node removal may also be performed if there's a concern about cancer spreading to nearby lymph nodes. The lymph nodes can then be examined to assess the cancer's spread, so subsequent treatment can be planned accordingly. The next treatment option is radiation therapy. Radiation therapy works by using high-energy rays or particles to damage the DNA in the cancer cells. This prevents the cancer cells from multiplying and ultimately leads to their destruction. Radiation therapy is frequently used after a mastectomy. It may also be used following breast-conserving surgery to reduce the risk of cancer recurrence in the same breast or nearby lymph nodes. Additionally, it may also be considered in cases where the cancer has metastasized. There are two types of radiation therapy used for breast cancer. The first is external beam radiation therapy, or EBRT. EBRT delivers radiation from a machine directed at the area of where the breast cancer is directed at the area of the breast where the cancer is present or was removed. It is the predominant form of radiation treatment for women diagnosed with breast cancer. Types of EBRT include whole breast radiation, accelerated partial breast irradiation, and chest wall radiation. The other type is brachytherapy, or internal radiation therapy. This method involves placing small radioactive pellets or seeds directly into the area where the tumor was removed. There are two forms of brachytherapy used in breast cancer treatment: intracavity brachytherapy and interstitial brachytherapy. The third treatment option is chemotherapy. Chemotherapy uses powerful medications to target and eliminate rapidly dividing cells, including cancer cells. It can be given either as an oral medication or as an intravenous infusion. Chemotherapy may be administered either before surgery to reduce the size of the breast cancer tumor or after surgery to help prevent cancer recurrence. Hormone therapy is the fourth treatment option. This treatment blocks estrogen and progesterone from attaching to receptors in hormone receptor positive breast cancer cells. This inhibits the breast cells from growing, or the cancer cells from growing. Hormone therapy can be used both before and after surgery to improve outcomes. The next treatment option is targeted drug therapy. This approach targets specific proteins that support cancer cell growth and spread. The goal is to block or interfere with the processes that allow cancer cells to survive, grow, and spread, either by suppressing their growth or inducing cell death. The last treatment option we will discuss is immunotherapy. Immunotherapy works by stimulating the individual's immune system, enhancing its capability to recognize and eliminate cancer cells more effectively. For more details on breast cancer treatment options, please refer to the American Cancer Society's Treating Breast Cancer. A link has been placed on the resources slide at the end of the presentation. According to the American Cancer Society's Breast Cancer Facts and Figures 2024-2025, the overall 5-year relative survival rate for breast cancer across all stages is 91%. This rate decreases to 86% at 10 years and 81% at 15 years following diagnosis. They further divide these statistics based on the stage of the cancer. A localized stage indicates the invasive cancer remains confined to the breast. A regional stage means the cancer has metastasized beyond the breast to nearby tissues or lymph nodes. A distant stage refers to the cancer that has metastasized to other parts of the body, such as the lungs, liver, or bones. The 5-year relative survival rate is 99% for cases detected at the localized rate, 87% for regional cases, and 32% when diagnosed at the distant stage. There are several preventive measures individuals can take to reduce the risk of developing breast cancer. The first preventive measure is performing a monthly breast self-exam. By regularly examining their breasts, women can become more aware of what is normal for them. This makes it easier to identify any changes in size, shape, color, or presence of lumps or other abnormalities, which should be reported to a healthcare provider for further evaluation. Next is maintaining a healthy body weight. Keeping a healthy body weight is widely recognized as a way to lower cancer risk. Being overweight or obese, especially after menopause, raises the risk of several types of cancer, including breast cancer. The third preventive measure is getting regular physical activity. Regular physical activity can help manage body weight, balance hormone levels, and strengthen the immune system, all which may help reduce breast cancer risk. The American Cancer Society recommends that adults participate in 150 to 300 minutes of moderate intensity exercise, or 75 to 150 minutes of vigorous intensity activity each week. In addition, the CDC advises incorporating muscle strengthening activities on at least 2 days per week. Consume a healthy diet is the fourth preventive measure. A healthy diet should consist of plenty of fruits, vegetables, and whole grains, while limiting unhealthy fats, added sugars, red meat, and processed foods. Poor dietary habits can contribute to obesity, a known cancer risk factor. The fifth preventive measure is drinking in moderation or abstaining from alcohol use. Alcohol consumption has been shown to elevate the risk of breast cancer. Even low levels of alcohol intake have been associated with an increased risk. For women, drinking in moderation is defined as having no more than 1 drink per day. However, it is recommended that women abstain from drinking alcohol to help with reducing the risk for developing breast cancer. Next is quit smoking or never starting in the first place. Smoking is associated with an increased risk of breast cancer, particularly in premenopausal women. Avoiding smoking altogether can significantly lower cancer risk. The seventh preventive measure is reviewing and assessing the risks and benefits of menopausal hormone therapy. As previously mentioned, combination hormone therapy has the potential to elevate a woman's risk for developing breast cancer. Therefore, to minimize the risk, it is recommended women use hormone replacement therapy at the lowest effective dose for the shortest duration necessary to manage menopausal symptoms. The decision of whether to use menopausal hormone therapy should be made in collaboration with the person's healthcare provider after discussing the potential risks and benefits. Another preventive measure is to encourage women to breastfeed their children if possible. Research shows that breastfeeding can reduce a mother's risk of developing breast cancer. The longer a woman breastfeeds, the greater the protective benefit. For women at higher risk of developing breast cancer, such as those with BRCA1 or BRCA2 gene mutations, or a family history of the disease, the next preventive step involves discussion between the healthcare provider and the patient to explore whether additional options may be beneficial to lower the breast cancer risk. These include preventive medications such as estrogen receptor modulators and aromatase inhibitors, and preventive surgeries such as prophylactic mastectomy or oophorectomy. Finally, all eligible women should obtain screening mammography annually. Mammography remains one of the most reliable methods for early detection of breast cancer, which significantly improves treatment success and survival outcomes. Now let's review the Medicare coverage criteria for screening mammography. Medicare Part B provides coverage for screening mammography for female beneficiaries aged 35 and over. For women between the ages of 35 and 39, Medicare will cover one baseline mammogram. Medicare covers annual screening mammography for women aged 40 and over. Please note that at least 11 months must have passed since the last Medicare-covered mammogram in order for Medicare to cover the next one. To calculate the 11-month period, begin counting from the month after the last screening mammography. There is no copayment, coinsurance, or deductible if the healthcare provider accepts assignment. Per the Medicare Benefit Policy Manual, Chapter 15, Section 280.3, a doctor's prescription or referral is not required for coverage of the screening mammography. However, according to NCD 220.4, an order by a doctor of medicine or osteopathy is necessary for Medicare to cover a diagnostic mammogram. Medicare may cover diagnostic mammograms more than once a year if they are considered medically necessary. For instance, if a patient requires additional mammograms due to symptoms or abnormal findings, Medicare will provide coverage as long as the procedure is medically necessary. For a diagnostic mammogram, once the Part B deductible is met, the patient is responsible for covering 20% of the Medicare-approved amount. If a provider performs and bills both a screening mammogram and a diagnostic mammogram on the same day, use modifier GG to indicate the screening mammogram was converted to a diagnostic procedure. For more information on mammography and modifier GG, please view our Encore presentation titled Encore Modifier Monday, Mammography and Modifier GG. A link to this presentation can be found on the resources slide at the end of the presentation. Documentation for screening mammography include the date the service was provided, any follow-up care or counseling that was given following the procedure, and test results and documentation of any follow-up care or counseling that was given following evaluation of results. Ensure all documentation is dated and signed with the provider's credentials. Prior to completion of screening mammography, ensure the patient has met the eligibility and frequency criteria of this preventive service. Went forward too much. Breast Cancer Awareness Month serves as an important reminder for all Medicare Part B beneficiaries to schedule their annual breast cancer screening. Medicare Part B covers breast cancer screening as part of its preventive services benefit. Annual breast cancer screenings play a crucial role in early detection, helping ensure timely diagnosis and treatment. So as a recap, during today's webinar, we discussed background information about breast cancer, explained screening and tests used for detecting breast cancer, reviewed treatment options, discussed strategies for prevention, and reviewed the Medicare Part B coverage criteria for screening mammography. And I've included some helpful resources on the next two slides. This slide includes links from CMS, Code of Federal Regulations, and the U.S. Preventive Services Task Force websites, as well as the WPS Encore presentations on billing mammography titled Encore Preventive Services Mammography Services and Encore Modifier Monday Mammography and Modifier GG. The next slide contains links from the American Cancer Society's website. Please use these resources as a guide when reviewing the information covered in the presentation. So we are now at the end of the formal presentation. Please remember, if you have any questions, please put those questions into the chat. And if we don't get to your questions today during the presentation, we will send out a document to all participants with the answers following this webinar. So I'm just looking at the chat. And it looks like we do not have any questions, so I am going to move forward. But if you do have any questions, please feel free to put it in the chat and we can revisit that at the end. So for those attending today's live event, in a few minutes, you will receive an email thanking you for attending. And the email looks sort of like what you see on this left-hand side of your screen. Do not delete it without reading it. This email contains your certificate of achievement, as well as a link to take the survey. So if you haven't completed it already, please take a few moments to complete this customer satisfaction survey. The contact hours for this event can be found in this email should you require them for earning credit toward continuing education. So if you don't see it, please check your junk or spam folder. Make sure to add the WebEx email messenger@webex.com to your safe sender, safe receiver list to avoid these emails going to junk or spam. And if you've called into this webinar, just email us at wps.gha.education@wpsic.com with the name of this webinar and the phone number you used to log in, and we can email you your certificate of achievement. Following today's live event, if you think of any additional questions, you have 7 days from today to submit them. Send them to our education mailbox at that email address, wps.gha.education@wpsic.com. It's right here, as well as it was in the chat. And put screening mammography in the subject line. However, if you have claim-specific questions, please do not send those to provider outreach and education. Please direct those questions to our customer service department, as we do not have access to your claim information and therefore unable to look up claims. Also remember, we cannot accept any type of PHI or PII via email. If you haven't done so already, please take a few minutes now to complete a survey. Share with CMS and us about your experience today. Tell us about your experience, including what you liked, what we could do to improve, and suggestions for future education. Your feedback really is invaluable in helping us develop the education you need. We use your feedback to develop topics for future education. So there are several different options you can use to take the survey, depending on your preference. For those attending today's live event, the first option is to click the survey link in the chat. The other option is to take the survey on the CMS Qualtrics page. So when you exit the webinar, you'll be asked to go to an external site. And that external site is the CMS Qualtrics page for the survey. And the message will look sort of like we see right here, that little yellow triangle. That site is not spam, it's actually directing you straight to our survey. And we'll also add a survey link to the Encore presentation. Just click on the survey picture at the end of the Encore presentation video to take our customer satisfaction survey. Based on your feedback, we've added several enhanced features to improve your educational experience. Our Encore presentation videos now include chapters, making it easier for you to find key information quickly. We've also introduced training indicators during our webinar registration to help you identify the intended audience for each session. So a clinical one would say would have a C or say CLIN. Billing would have the bill. Medicare Part A, Medicare Part B, new to Medicare. Those have identifiers, so you can find out which one really appeals to you and will be beneficial for you. And we are hoping these enhancements do make your experience more valuable and accessible. Before we wrap up this webinar, I'd like to remind everyone about our upcoming Medicare Education Expo, Medicare Madness, on October 16th, starting at 9 a.m. Central Time and 10 a.m. Eastern Time. And the expo will focus on Medicare claims process. It will feature 6 individual sessions. To register, visit the training center on our website and click the live events icon. And I've also included a link to the registration page on this slide. So on behalf of myself, Mary Sue, and all of Provider Outreach and Education, thank you for attending today's webinar on screening mammography. As a reminder, this presentation will be posted as an encore presentation on the Training Center page on our website. Remember to take our survey with the link provided. We look forward to your survey comments and hope to have you join us at future events. You may now disconnect.